This week on the BackTable podcast.
We have to remember, this is from start to finish, from like the pathway of Y90. It's about $100,000 treatment. It's not a cheap treatment, right? So you have to have certain standards and aim for certain outcomes, right? Particularly if you're doing a segmental treatment, the goal should be to compete with ablation and surgical resection. Anything short of complete response is a failed treatment. You have to go either retreat, and there's always a failure rate for every treatment, right? But you cannot just be so happy-go-lucky about it that, oh yeah, we'll treat and we'll see what happens. And a lot of those centers, particularly OBLs, they don't even do a post-Y90 dosimetry. So you're completely in the dark, which is concerning to me.
Hey everybody, welcome to BackTable 190 Dosimetry University. I'm Kavi Krishnasamy. I'm an interventional radiologist. I'm an interventional oncologist at the University of Alabama, Birmingham. I have two amazing guests with me today, Nima Kokabi and Tyler Sandow. Nima, you want to introduce yourself and tell me what practice you're in? What kind of practice you're in?
I'm Nima Kokabi. I am at the University of North Carolina, Chapel Hill. I am the Director of Interventional Oncology and Vice Chair of Clinical Research for the Department of Radiology, and excited to be here.
Yeah, welcome.
Tyler Sandow, interventional radiologist, interventional oncologist at Ochsner Health, which is a multi-specialty clinic, kind of along the clinic model. I guess we joked about it, private-demics. I'm not an academic guy. I don't have as many fun titles as Nima does or as you do, Kavi. Since we are filmed, I do hope that they catch my beautiful reflection in this podcast.
Well, I appreciate that. Real quick, special shout out to some of our colleagues around the country in private practice, Austin Bourgeois, Chris Beck, and Michael Barazza for helping us put together the agenda for today. Nima, you're in academics. Tyler, you already said you're in private demics, and I'm in academics as well. So we like to think that we move forward, we're democratizing Y90 for the country and the world, and figuring out how we can better collaborate between academics and private practice. So anyway, without further ado, let's get started. Do you both have IR clinics?
We do.
Yes.
Do you both have multidisciplinary tumor boards and or multidisciplinary clinics?
We have both.
Okay. So we have many multidisciplinary tumor boards, one from a metastatic colorectal to a liver-specific tumor board to an upper GI tumor board to obviously, other ones, chest, GU. We do not have integrated multidisciplinary clinics as much as we would love to in a multi-specialty clinic model where we have many different campuses or many different hospitals. You can't just stack people at every one. And so we do have a central IR clinic that most of our patients get filtered through, and then we have two smaller IR clinics out in the community as well.
We actually have a multidisciplinary tumor board. We have multiple multidisciplinary tumor boards for different indications, but actually compared to Emory, where you and I were both, one of the biggest advantages I've seen at UNC is the multidisciplinary clinic that we have for liver cancer. So we get to see the patients at the same visit as hepatologists and medical oncologists, which I think is great for optimizing patient care and expediting it.
Yeah, I agree, and that's what we do as well. We actually have a HCC and colorectal multi-D clinics. IR for us is not as involved in colorectal multi-D clinic. We are in the tumor board, and then we're starting a neuroendocrine multi-D clinic. So for us, it's just, making the pace faster, effectively getting the patient from tumor board or initial entry into the UAB system to then treatment, right? And so that's kind of the way we look at it.
And I think all of us are in practices where people come from far distances to see us. Yeah. It makes a huge difference having those multi-D clinics, because for me, an average person in North Carolina, in terms of commute to come to Chapel Hill, is 2 to 3 hours, if not longer, actually. So if we can do, and we're going to talk about hopefully some of those kind of approaches to reduce the time to treatment and care for the patient. I think if we can reduce their time or the number of visits, that's another way to kind of get that.
If I could interject real quick, I do think multidisciplinary clinics are wonderful. Yeah. And I think in a perfect world, we would all do that.
Agreed.
But I think at large institutions like y'all's, and we're pretty large as well, it makes sense. And it should probably be because you can have more face-to-face interaction with the oncologist and see, or surgical oncologist or hepatologist or transplant surgeon, whoever is seeing the patient, there can be more timely interactions and engagement. that may not be feasible
Great.
for
That's also a
people
great
in
point. Yeah.
private practice or people in practices not as large as y'all's. And so I think another consideration to try to help improve the time to treatment or the communication might be to increase the engagement with your referring clinicians. So Juan Jimenez, I got to always give him a shout out every time we talk about this, is he responds to messages probably within 10 seconds of getting them. In our text, we're always available via phone for phone calls and anything like that. I think the more you engage with your referring provider, so people that don't have the multidisciplinary clinic option available to them, the more you engage with your referring providers, the more you're readily available, the more likely you are to improve in a scenario where you may not have the option to have a multidisciplinary clinic.
Tyler, your point is very well taken. My phone is on 24 hours a day, 7 days a week, whether I'm in the country, out of the country, and I respond. And I'm not advocating that everybody has to do that, but that is the way that I approach it. I think what you guys also do that is also very beneficial for your patients is you actively put them on the schedule for mapping and treatment very fast, correct?
Mm-hmm. Yes. We don't schedule our treatments until after the mapping, right? Because the mapping to us is a diagnostic study, but we do try to roll that in as quickly as possible. And we have schedulers dedicated to getting our Y90 patients on the schedule as quick as possible. I am going to test you on this 24/7 availability. I'll call you at 3 a.m. this morning.
Deal.
And I look forward to your response.
I don't wake up to text messages.
I'll call you. Be ready.
Yes, okay. So average time from clinic visit or multidisciplinary tumor board discussion to mapping for you?
Okay, so the way it works for us, great question, and it was not always good, right? So we'll talk about this in a little bit. Our volume is, we do north of 300 Y90 treatments, individual treatments a year. And trying to coordinate all that is a masterpiece. And so our coordinators do a wonderful job on that end. When a patient gets reviewed in our liver conference, and let's say they have HCC and they decide that they need Y90, the first person that needs to initiate that conversation is the referring provider, right? That they don't need a call from our coordinator saying that you have HCC and you need to come to IR clinic to talk about a Y90. The person that has rapport with the patient should be the one communicating that. So we have that established at our system. Our hepatologist or oncologist or whoever it may be will then send a message to our system, and the clock starts right there. From that point, our lag time to get patients in clinic is same week. So we've improved on that. Juan has done an incredible job with our APPs and our schedulers and our IR group as a whole to get patients in same week. So they get seen in clinic same week. The time to booking on the schedule for most of us, some of us only do certain types of Y90 case, some of us do some of the more complex stuff, is about 1 week. So they get clinic same week. 1 week later was a mapping, and then our time to put them on the schedule from after mapping is somewhere between 2 to 3 weeks.
Okay, for treatment.
For treatment.
Okay.
Who sees the patients in clinic for you guys?
So it's, in a perfect world, it's our IR physicians. Right now, we are short-staffed, and we won't have this problem in August anymore. But the APPs, unless there are specific communications that need to be relayed to the patient. So right now, it's our APPs only because we have to cover all of the clinics and all of the hospitals that are associated with Ochsner's footprint. We have to have boots on the ground, and we can't put them in clinics. So once we get the 3 new hires that I was telling you about this morning, we're going to be able to see everybody in clinic as quickly as possible.
Because I think that is one of the reasons you get to see them earlier than usual, because you're utilizing your APPs
100%.
Greatly to that end. For us, we see them about 1 to 2 weeks after the referral has been made or the discussion has been made in the tumor board in terms of the liver-directed therapy of any sort. And then after that, the scheduling depends on if you want to use resin or glass. If you want to use glass, we do them separately, meaning do the mapping, just like what Tyler said, and do the treatment afterwards. After the mapping schedule for the treatment. For resin, we actually do order, map, treat. We generally, depending on our schedule, for example, for myself, I do the mapping on a Monday, treatment on a Tuesday, 2 weeks out from the day I see them in clinic, just to give our pre-certification people enough time to get the insurance approvals and whatnot. 98% of the time, anecdotally, it will go according to plan and you get to treat the patient, but there will be times that you may have to cancel the treatment. But overall, it's worked really nicely in terms of expediting care. for those patients.
Yeah, that's a great point.
You brought up a great point. The pre-certification to get you have to get insurance approval for a lot of these, right? That Medicare is very easy to get approval for, but for some of these private insurers, they have a 2-week turnaround to approval. And so like you said, that 2-week gap it should not go unnoticed, right? So sometimes you might see the patient in clinic, but you might have to wait 2 weeks before you get the mapping and or the treatment.
So that's a great point. We looked back at our data. We found that our HCC patients in particular, not METs, but HCC patients were not getting denials. So we scheduled clinic and mapping back to back as quickly as possible, and then schedule the treatment a little bit farther out to account for that insurance authorization piece of it. So our goal is treatment within 4 weeks of clinic. Doesn't really always work out that way, but that's what we try to do.
Actually, even with the order map treat, we haven't had any issues with denial.
Okay.
And I know we're going to talk for anything.
Oh, well, okay.
For anything.
Okay.
And we'll talk a little bit later, as we discussed this morning, about a single session Y90 going straight to treatment for certain cases. Even those, and I was surprised when we started it. I thought for sure some insurance companies are going to push back on that. And I know you've done some single sessions as well. Yeah. I haven't had any issues with insurance companies.
I think it depends on what you treat. And I think it all depends on who's looking at it and how focused they are when they're paying attention, right? HCC, if you look at all, so actually I love arguing. I love doing the peer-to-peer stuff because it gives me an opportunity to assess who I'm talking to, right? So you might be dealing with a peds nephrologist or a peds rheumatologist or an neuro-ophthalmologist who's denying your request to do Y90 for somebody with metastatic colorectal cancer where it's actually indicated in their policy. So I've actually looked at a lot of their policies, and some of it they highlight specific things, right? Like if it's HCC, it's a easy pass through. It just needs to be appropriately documented that it doesn't meet criteria for ablation or resection, or it's not an ablatable candidate. So you have to make sure that you document well in your chart and that you're probably not having issues, because when you are submitting your claim pre-cert, when you're submitting it with the appropriate documentation to say, doesn't meet criteria for any of these other indications, therefore Y90 is the indicated treatment. Now, sometimes, like if you're treating like a gastric met or an RCC met.
Or breast cancer.
Or breast, they will give you shit. I mean, and it's reasonable. And I understand where they're coming from, right? You got to keep the lights on, and in their eyes, it's considered experimental. But I do think patients do strive to benefit or do stand to benefit from these treatments. And so I'm all about arguing peer-to-peer for these.
Well, I have a long met on the schedule in a couple of weeks, and that's exactly the route that I had to go. And it's a 4-centimeter lesion in the dome that I didn't think I could adequately ablate, and the patient didn't want resection or was not a resection candidate. And so what else are we going to offer, right? And that was the exact conversation, and it got through peer-to-peer, to your point. So anyway, I want to get back to a little bit of dosimetry stuff. That is the reason we're the three of us are here, and I know we're all very passionate about it. So glass versus resin. What's your both of your splits? What tumor types are you treating? Primary versus mets.
So we are basically 100% glass. We've been that way probably for about 6 years. The majority of our practice, we are a transplant center, so we do have a lot of inflow associated with transplant, and that being HCC as the primary driver. Most recently, we've expanded one of our multidisciplinary conferences to metastatic colorectal. Our involvement in that metastatic colorectal conference has been awesome. We actually run the conference, do the imaging review with our surgical oncologist and our oncologist on board. So we actually do a fair amount of metastatic colorectal now. We do a lot of neuroendocrine, but for those patients, those are primarily TACE. So I will say we're probably 80% HCC or 75% HCC with another, 5% being cholangio and maybe 20% metastatic colorectal or metastatic disease.
Metastatic disease, okay.
So mine is a little bit more of a historic context, and you and I worked with each other at Emory. So pre-flex dose for me was a very clear split. Anything HCC or segmental, I was using glass. Yeah. Anything multifocal, and many practices around the country, actually, they still practice that way. So anything multifocal or lobar, particularly metastatic setting, they would use resin. So, and that's how we were at Emory, if you remember. And then because of some involvement I had in research projects with resin, when Flex came out, I started to, and I had the concerns that many people have with the day of calibration resin that, oh, too many particles, not hot enough, you could get stasis, incomplete treatment, et cetera, et cetera. Even though some data has been published on that, but not much in the United States at least. So I had the same concern. So once Flex came out, I started using it in a clinical trial setting, and then I realized, and at that time it was only 2 and 3 day pre-cals available for the SCOUT study, if you remember. I started using it, and I actually realized that I'm not getting any stasis. I'm getting good results. So I started using it more. In Atlanta, when I was at Emory, it was still about, maybe at the end of it, it was 60% resin, 40% glass for me. When I got to North Carolina, this whole issue of how far the patients travel from and the catchment area that we have, it really made it more conducive for me to use resin for the fact that I bring them, I do the mapping, they stay overnight at a hotel or somewhere close by, and I treat them the next day. And that is purely why I'm using more and more resin. On a practice level, we are about 50-50 glass and resin. But for myself, I'm close to 100% resin now because of the whole efficiency and convenience factor.
Sure.
Yeah.
And it's HCC and METs.
HCC and METs. Yeah.
Yeah, we're about 75-25 on a practice, from a practice standpoint. A lot of HCC.
75-25.
Glass, sorry, good question. Glass resin. A lot of HCC, some cholangio. We tend to see a lot of advanced cholangio, and then our METs. We're growing our METs side of the practice. So colorectal, some neuroendocrine, and then random like lung MET, things like that. So that's kind of where we are. But I think 6 and 7 day pre-cal. To your point, we're at 5 day pre-cal. 6 and 7 are coming. I think we're very excited about that. So that'll be nice to see. When we have access to that. Dosimetry guidelines documents, dosimetry apps. Helpful, not helpful? Do you both use them?
I think it's great for guidance, right? Like I think, so there's, Riyadh put one out for glass, and they've updated it again.
And the next one just came out, right?
Yes, right. And then, so the most recent one for HCC was in 2022, and they gave you different guidelines for different scenarios that you might encounter, right? There might be a rad lobectomy, rad segmentectomy, might be multifocal, where you're talking about, and then, other things where you're doing bilobar, metastatic disease, where you're talking about dose to normal. I think those are great for people that don't do this routinely, where it's not on the back. Where I'm always thinking about these kind of things, and I don't actually feel like I need to go back and reference them. But I think it's a great document. Whenever we tell people, how you should practice, follow what's published, right? And that's the dosimetry guidelines that are established there. I think that's very helpful. And Nima, I think y'all are working on one for resin as well.
Yes, we are.
And so I think that gives people good reference points, especially when you're not doing it all the time or enough to where it's just you can flip back to it in the back of your mind.
Trainees coming out of fellowship, right? I mean,
100%
out of residency. So I think.
And what I like I think they're incredibly important. There's a resin one that was published, a glass one for HCC that Tyler mentioned.
Resin one's a little bit on the old side.
Older side. That's why we are updating it, and it was encompassing both METs and primary, and it was all with the day of calibration. And we'll talk about how things have changed. The point, and hopefully by the end of this podcast, what we will get through is the approach, the different devices, obviously, in terms of dosimetry. So you have to know the different thresholds, how to plan, etc. But what I love about the glass consensus guideline that for the HCC and even for the METs that they publish, they have very strong emphasis on treatment intent and not losing sight of that, because it really dictates how you approach it from a dosimetry standpoint. I think historically, a lot of us have probably over-treated a lot of metastatic patients because of the fact that we would not be satisfied until we see no residual disease. But we have to kind of train ourselves to think more like a radiation oncologist for those palliative cases, that disease control is actually a win in those cases. You don't have to kill the patient in the process of killing the tumor, so to speak. And that's why I think those consensus guidelines could be very valuable in terms of, particularly for the less experienced centers and the trainees, to kind of compartmentalize the 5 scenarios that they have. I think it's a very nicely done approach. So I think they're important.
It's not, it's not that long ago that we were just doing 120 gray MERD into the right lobe of the liver.
For everybody.
Or 100 gray MERD.
Or BSA for everybody.
Or BSA for everybody. I mean, this was, not even 10 years ago we were doing this, right? And so really, there's been a lot of evolution of dosimetry apps.
Yeah.
I know Daver is kind of sunsetted. It's not available on.
Well, you can't get it on.
Can't get it anymore. I still have it.
Yeah.
I
Don't delete it if you have it.
Don't do it if you have it.
Yeah.
I use the Cancer 190 app a lot still. I know that the glass estimates on the Cancer 190 app are not accurate anymore. The resin estimates are for sphere activity and
Armin Mahavash from MD Anderson is the owner of Cancer. He designed the Cancer 190 app. From my discussion with him, they're updating it for the calibrations, the updated calibration for glass, and also making it available on Android, because for a while it was Android compatible as well, and then it wasn't anymore.
Okay.
So I use that one. I think there, again, Tyler's point, it's good to have it, particularly if you don't have access to other means of dosimetry.
Yeah.
It's freely available. Is it the end all be all? No.
It's a tool.
Yeah, it's a tool.
Right.
Hopefully for confirmatory measures, at least, that, okay, I'm giving this much activity to this volume of a segment or a lobe, and we'll get into particle distribution and density based on what is published out there for both glass and resin. Am I giving adequate coverage? Am I giving adequate dose? So again, one tool in the toolbox.
Yeah. And I think definitely helpful on the resin side. On the glass side, you're using the TWI in the spreadsheet. Are you actively looking at particle count? Does the app help you?
So I will say this, and we're probably going to disagree on the particle count and coverage thing at some point down the road, so we might as well just...
I'm just delaying the conversation, man.
I know, I can tell. We can bring the elephant in the room. I don't use the app as much. I haven't found much of a need for it because of the way my practice is structured. And I think the TWI worksheet, which for the majority of what we're doing, we're talking about uni-compartment MERD dosimetry, which is the most simplest form of dosimetry. I think BSA is very simple, but it's very inaccurate. I think MERD is probably the one that gives you a fair amount of accuracy, and it's the most simple to use.
For RadSeg.
For RadSeg. And also,
segmental.
Segmental. And we can...
Yes.
I'm sure we're going to get down the partition game as well. MERD dosimetry is very simple to use, and so the TWI worksheet gives you that kind of information. We use Simplicity, which is, it allows us to kind of calculate all that stuff in
That's your dosimetry software platform.
Yes, right. But that allows us to get the dose and just do simple uni-compartment dosimetry that way. Otherwise, I'd be using before we use Simplicity, we use the TWI worksheet.
And then you use MIM. I also use MIM as well. I do all my contouring and lung shunts and all that thing. How do you feel about MIM?
I'm a little bit biased towards MIM because I got to use it as a resident when I was doing dosimetry research. We had it at Emory back in 2011, 2012. So I like it. It has changed significantly in terms of becoming easy to use with the AI components that it has. It contours the lungs and the livers automatically once you open a SPECT CT. The biggest difference between the two softwares, and we've done courses on these in terms of dosimetry at many conferences, including SIO, at least according to FDA, you are not allowed to calculate the T/N ratio. Well, you can calculate the T/N ratio, but you cannot go further than that if you want to use partition model dosimetry.
On the MAA spec.
On the MAA spec, because the point FDA makes, and that could be a point of discussion here as well, is that MAA is not an accurate surrogate for Y90. So they don't want to basically approve a dosimetry software to be used for partition model dosimetry using the MAA data. But that's the best we have at this point.
I agree with you on those points too. And I will say MIM has come a very long way in the last 5 years. We used to use MIM too. I mean, it honestly 5 years ago kind of sucked. I mean,
it would take an hour to do one single planning.
But it's not that way anymore. It's
5 minutes now.
Yeah, the AI components have really advanced, and I'm very impressed with the software.
So Kavi remembers we had about 20 nuclear medicine physicians at Emory. They were doing all our dosimetries. I get to know all of it. Yeah, it would take a long time. Yeah. And I realized that we don't have as big of a nuclear medicine division. So I had to teach myself how to do it. And I was scared. Initially, I was like, oh my goodness, it's going to take me half an hour to do. But with the whole MIM protege and the AI component, literally for particularly the simpler stuff like a segmental treatments that we do quite a number of, less than 5 minutes to do.
Yeah. And we need to understand, y'all are in academics, we're in private-demics. You might have a little bit more time to do this. But people that are trying to read studies in between trying to do cases, you got to make it quick and easy, right? Because somebody's got to be able to reproduce this and run on it. And so rather than then, mentally harness all the things associated with the great software. We got to make it quick and easy.
I will say though that, when I'm using MIM and dosing a case, it's usually at 7 or 8 at night. So it's not during the word.
Another point, so now that both softwares have improved significantly, in my opinion, both, and there are other dosimetry softwares, but both softwares, but by both, I mean Simplicity and MIM, there's actually a economic components as well to it in the private practice and even in academics, that if you do the work, you might as well get paid for it. Yeah. So you can actually get reimbursed for the pre-treatment.
Yes.
And you can get reimbursed for the post-Y90 dosimetry confirmation, which we can talk about later as well.
But you have to document, right?
You have to make sure your coders know to bill for it.
Yeah, that's true.
So there's an educational component.
Yes.
So I want to skip the post-dosimetry part. We'll come back to that. Pre-dosimetry or MAA dosimetry, what values, what numbers do you absolutely want to have to dose a case?
Depends. Segmental treatment, I think for either, and this is what I've kind of borrowed over the years from glass data, I think partition model dosimetry for segmental is an overkill. I think Shamar is going to probably call me after he sees this episode and give me his opinion. But because what are we trying to achieve? We're trying to kill that segment, right? So you don't need to become too fancy about it at all. I want my tumor to get this dose and my non-tumoral portion of the segment to get this dose. So I use single compartment dosimetry, whether I would do glass or resin for segmentectomy. Where I think partition model really excels is when we are talking about those colorectals and the multifocal cases that really there is no downstaging to surgical resection for most of them. What they have, they've been treated with 3-4 lines of chemotherapy before they come across your clinic. You really want to make sure that you don't tip them into liver decompensation or failure.
Totally. But that's where you need partition, right?
I think so. Yeah.
Go ahead.
We haven't explained partition yet.
We haven't explained.
So
we're jumping the gun a little bit.
Before you jump down that road. So I think I do want to ask a question about partition because we should talk about that next. I think when we're doing a rad seg, the things that I care about are perfused volume and lung shunt fraction, right? So I calculate, because that's my perfused volume is going to be the area that I treat. And so I use a cone beam CT to calculate that. Some people actually just map out a segment and they say, they do anatomical dosimetry where they just say like, I'm going to treat segment 8, so I'm going to calculate the volume of segment 8. We do what's more functional based. Yeah. So we'll do a cone beam CT from the area we intend to treat. And we measure that volume based on the cone beam CT, and that becomes the volume that we enter when we're going to order a specific activity to target a specific dose. And I agree with you on the component of looking at the T-to-N ratio in a rad seg is overkill on the pre-end, but we do have to recognize that there is preferential flow to hypervascular lesions in a rad seg that will play a role when you think about how you're going to dose your rad seg. And I think there will be nuances to that we can dive down there. But I don't want to poo-poo the T-to-N, but I also don't want to neglect it either. So partition.
So do you calculate T-to-N for rad seg?
No.
Okay.
But do I recognize that it happens? Yes. And
of course.
I have a threshold dose for the way that I like to do it. And I like to do subsegmentectomy. So my perfused volumes are kind of around the tune of 150 mLs for the most part. If you are treating a 5 centimeter tumor and 150 mLs worth of volume, that 5 centimeter tumor occupies a very large portion of that. So if I dose at 400 and I want the tumor to get an ablative dose, the tumor is probably only going to get a dose of 400 gray. Now, if I dose it at 600, the tumor will get closer to 600 or 800. So, but if the tumor is 2 centimeters and the perfused volume is 100, a 2 centimeter tumor, assuming it's a sphere, is about 4 mLs worth of volume. So 100 divided by 4. So your angiosome to tumor volume ratio, which I think will play a role down the road, is 25-1. So there's going to be preferential flow up to a certain point to the tumor, right? So the tumor will absorb more, but a sponge can only hold so much water at some point. The yield is low, but there will be preferential flow before you become completely embolic to the tumor. And so 400 gray in that territory might actually have a higher T-to-N ratio. And even if it's 3-1 or 2-1, the tumor's getting, if you go 400 gray to that perfused territory, the tumor might be actually receiving a dose of 1200 or 800 gray, right? Mm-hmm. And so I think those kind of things matter. I don't actually, I think we go in there, like you said, when you think about RadSec, I think about ablative intent of a territory. If it dies, it dies. But I think you also say that there will be preferential flow to where the tumor is up to a point.
I want to clarify one thing. So I want to go back to, and this goes back to Razor, right? And so Razor, the tumor got 1,000 plus gray because of the TNR in the perfused segment, right?
Correct.
They didn't give 1,000
They were
gray.
smaller tumor.
They were smaller, agreed.
I think it was all 3.
They were all less than 3, which is the majority of what Legacy was. 2/3 of the tumors in Legacy were less than 3 centimeters. But the perfused volume dose was 584 or closer to 600, right? And so so they were treating smaller tumors, and then their perfused territories were smaller, but the tumor doses were closer to 1,000 gray.
And so the tumor volume to perfused volume ratio comes into play, and then the TNR comes into play as well, right? And to your point, when I'm dosing a tumor and the tumor occupies the majority of the segment that I'm dosing, I'm escalating my dose on purpose to that point, right? Because if I get 400 gray straight to tumor, the tumor's just going to get 400 gray. It's not going to get 1,000 gray.
Correct.
So
I don't spend a lot of time, so let's re-simplify this. I don't spend time thinking about this shit. That takes way too much mental energy. I just assume that if I raise my floor, not just to 400, but if I raise my floor to 600 or 800, whatever, I'm getting more statistical probability of being lethal in that tumor. And so that's how I approach it. But let's talk about partition, because I think partition's important for people to understand since we brought it up.
So I like the cone beam CT volume measurement. I think it makes it simple. I think it's definitely more accurate than the volume measurement on anatomical scans, because we go always with a preconceived notion, oh, this is going to be a chip shot, it's going to be a single feeder, corner of segment 6, and we always often get surprised that even the simplest location may not actually have the simplest angiosomes.
part of it is, number one goal is kill tumor.
Yeah.
Number two goal is spare normal liver.
Yeah.
Especially with ablative doses, right? So if I can work to get more selective and spare 200 cc's of normal liver, I will do that 100 times. 100, as we all will, right? So I want to come back to partition. I'm sorry, I don't mean to cut off that conversation. I want to hit on a couple of other topics before we get there. Angiographic vendor. And are you using angiographic targeting software?
So we have Siemens for our suites. And you've seen our shop. We like it because we're in South Louisiana, and Popeye's poisoning is a real thing. So we got bigger patients.
Yeah.
We have Bojangles.
Yeah. We got, hey, look, man, we also got, we got Bourbon Street, which keeps us in business too. But you can do wide cone beam CTs, the swing on a cone beam CT. So we can actually have the patient's arms down by their side.
This is the Artis or the Condo platform?
The Artis. Yeah. And so we can do cone beam CTs a lot more comfortably and efficiently, and that makes our practice run smoother. So our mappings don't take quite as long because we don't have to worry about arms down, arms up, arms down, arms up.
Yeah.
I like Philips. I used it in fellowship. I would associate it as more of like an iPhone. It's more functionally simple to use. Siemens, I think you can do a lot of fun things, but you have to know how to dive down that road. I don't use ImboGuide. The way I approach it, and we'll probably talk about this down the road, is that I like to do proximal or lobar cone beam CTs to assume complete tumor coverage, and then I'll do cone beam CTs from the area I intend to treat, and I make sure that I have the same tumor coverage that I did on the lobar that I do in the more distal cone beam CTs to see complete tumor coverage.
I use Siemens as well. We have Siemens, and it's Artis. So, and we have patients on the bigger side of things as well, and we do a lot of radial. Our go-to is radial, and we should probably talk about that at one point of what is your go-to axis and why. I use EmboGuide all the time. I usually do a cone beam CT proximal from a common hepatic or proper hepatic. Get the use the EmboGuide to see what the feeders are, and then when I select it, I will confirm again with a second a more selective cone beam CT, and go from there. And I was telling Tyler this morning, sometimes I say this is definitely not true what the software is suggesting, but more often than not, the software proves me wrong.
And there's data that supports that, right? I mean, there is data that the targeting angiographic softwares will catch things that our eyes will not catch. I think where I struggle a little bit with targeting software, it's a great confirmatory tool. I don't like to leave it on live because a lot of my cases are multi-dose cases. And then you have, 4 different vessels that are crisscrossing on top of each other, and I can't figure out where I'm going.
I don't use the live option.
I don't use a live option either. I do like it for confirmation, but I don't use a live option. You like to stay in the room for your cone beams?
Yes.
Right?
I do.
And you just shield.
Big shield.
And inject, do your cone beams.
Well, so no. So I will say this, let's not say we always hand inject.
Okay, all right. Sorry.
But, and Nima brings up a great point too, which I think this is why we all get good results. You do proximal cone beams. I think you have to do proximal cone beams with a power injector to show what the tumor is looking like. And I think one of the keys to success is making sure you do an incredible mapping. And so you emphasize this as well. A power injection, proximal cone beam, whether it be in the proper hepatic artery or in a lobar branch, you can see how the tumor is covered by the feeding vessels. So we do power injection cone beams proximally. As you get further out and you're doing your selective cone beam CTs, which you're going to use to calculate your MERD or your perfused volume doses, you don't want reflux. So now power injection can become problematic if you are refluxing the vessel when it comes time to calculate those doses. So I actually prefer to inject those by hand so that I'm not refluxing.
And I think a lot of the older injectors, you had a minimum cutoff
Correct.
of how low you could go. My current injector, I can go down to 0.2, 0.3 cc's a second. So sometimes I will just power inject in those cases. But that's
Do you ever hand inject?
Every once in a while.
I have never hand injected.
I learned it from Tyler.
Yeah.
That's where I got it.
Because we did a lot of PAEs at Emory, and we were using 0.3, and they actually worked nicely without any reflux. So I was always used to. For segmental, 0.3 to 0.5 ml for whatever usually it's a 13.
Hey, look, I think there's nothing wrong with power injecting. Like I would just say that my experience with power injecting, especially with doing these 150 sub 100 ml perfused volumes, is that there will be reflux if you're not controlling for it.
Yeah,
like even at 0.2 or 0.1. And so, I mean, these forearms, I mean, they can squeeze some contrast out. And I can't beat a power injector, but I can also control. I'm watching in real time what's happening as things are flowing. And so I think it's fine to do it both ways. I think you just need to understand the limitations to both. I'm getting a slightly higher radiation dose because I'm in the room doing the cone beam CT.
But you're shielding yourself.
But I am, shielding. I'm not dumb enough to just like go
you're not
spread open and get me,
Well, I mean, but you have the ceiling shield and a tableside shield in addition to wearing lead, right?
Yes,
so you're actively shielding like I would in CT fluoro.
Correct. So, and I will say we do a fair amount of cone beam CT because, again, you're doing a low bar proximal powers and then you're doing more distal confirmatory, and our radiation doses are on the low end. I mean, we routinely stay below 1 gray during a pretty complex map.
So in the interest of being controversial, since we have Tyler here, do you think people that don't do cone beam CT or don't have cone beam CT should be doing Y90?
I would say there are limitations. There are some people that don't have it available, right? There's some sites that you just can't do it. And you might be the only person that can do Y90 in your state, and you may not have it. And so without saying that, I don't want to say it's malpractice. I would say if you have it available and you're not using it, that's a problem. Because I think that I have seen so many things, and you highlighted this with IMBO guide, right? There's so many times where you would think it's going to be one feeding vessel and it winds up being something entirely different. And so cone beam CT is an integral part of the mapping, and it is part of the diagnostic workup. And if you have that diagnostic tool available, the patient needs to benefit from you using that diagnostic tool to treat them appropriately. Not everybody has access to that. And so that's where sometimes spec CT, you might actually have to use some of these other confirmatory things down the road. So I don't want to say that it is substandard care if you have it readily available and you don't use it. And I think everyone that does Y90 should do everything possible to make sure that they do have access to cone beam CT. And I think that you should fight with your institutions or your hospitals to provide this kind of thing. I don't think it's fair for the patient to go get a Y90 expecting the same result that you guys provide when there's somebody else somewhere else that's not doing cone beam CT. Like, everyone deserves to have the best possible outcome for them. And I think that you're asking the right question, and I'm trying not to just be a total.
I think the conversation is also different if we're talking about a peripheral 3 centimeter lesion in segment 6 versus an 8 centimeter central lesion, right? Like, that conversation is completely different.
Sure.
Can you get away with a segment 6 lesion without cone beam and use a spec CT as a confirmatory? Probably, but I don't know that I would ever advocate for a central.
Well, I don't think you can honestly tell me that you got complete tumor coverage, or you can totally. I don't think you can give me the same assurance that 100%. I can give you with cone beam CT.
100%. But if you didn't have it.
Yeah, if you didn't have it. But if you have it and you're not using it, yeah, there's a problem there.
I don't know how many institutions don't actually have it. If a machine is 10 years or younger, they usually have it, unless we're talking about OBLs, right?
We're talking about
The
OBLs.
concern that I have with OBLs, and people are going to hate me for saying this, is that those are the ones that actually don't do SPECT CT either.
Yeah.
So they have no cone beam, they don't do SPECT CT, and they want to do Y90. How? And we do, collectively between the three of us, we probably do close to 500 to 600 Y90s a year. Okay. How many times do you get humbled by, you go to a case and you say, I guarantee you it's one vessel, and you go in and you're totally missing, or you're missing half of it.
Oh, it happens once a week.
Yes, exactly.
It happens every other day to me. Actually.
Yeah. So that's my concern, that maybe not everybody should be doing it, you know?
Yeah.
So yes, of course, the goal of this podcast, one of the goals is to make sure, as you said, to spread the
Democratize,
expertise,
right? So,
that everybody does it, but not everybody can do open heart surgery.
Well, and
You know?
agreed. And I will say, this is not just opinion, right? There is data that supports, you will find additional feeders on cone beam CT that you don't visualize on DSA, right? That is well known. We all know that. There's data that supports you can use anatomic volumes, but they're inaccurate compared to perfused volumes. How many times can you go into a case, oh, this is going to come off of segment 8, and it comes off of segment 4 or something weird, right? So you can't predict these things. This is why I'm sure we all advocate mapping first before you decide what you're going to do, right? Always map, and then maybe the patient's not.
You know, we have to remember, this is from start to finish, from like the pathway of Y90. It's about $100,000 treatment. It's not a cheap treatment, right? So you have to have certain standards and aim for certain outcomes, right? Particularly if you're doing a segmental treatment, the goal should be to compete with ablation and surgical resection. Anything short of complete response is a failed treatment. You have to go either retreat, and there's always a failure rate for every treatment, right? But you cannot just be so happy-go-lucky about it that, oh yeah, we'll treat and we'll see what happens. And a lot of those centers, particularly OBLs, they don't even do a post-Y90 dosimetry. So you're completely in the dark.
Yeah.
Which is concerning to me.
I agree. And I think you bring up with open heart surgery, you bring up a very valid statement. What you got to do is you got to try to optimize everything as best as you can for the patient. And you'll be surprised at the number of sites that don't have cone beam CT. So we've had other sites, and not Ochsner affiliated, but we wound up getting referrals from patients that had either, incomplete responses or failed responses, and for what should have been very simple stuff. And we go in and we review cases, and we have to say like, hey, look, well, you missed the vessel, and there was no cone beam to confirm that. And so you have to raise the bar if you're going to compete in this level. If you're going to compete with surgeons, you're going to compete with
or SBRT.
Yes, or RAD-oncs.
RAD-oncs are getting great response. I mean, we can deny it all we want. I work with a lot of good RAD-oncs, and we are very collaborative. They get good results.
Yeah.
So if we keep going down this road of, oh yeah, let's simplify it. And this is the point of this podcast. We want to simplify it as much as possible, but there has to be minimum standard for this treatment, that this is not a taste that you just go and hope for the best and you bring them back and do a second time and a third time. And you could do that, but that shouldn't be the norm.
Yeah, that's not the aim.
Yes.
Well, and by no means am I saying that you don't need to have cone beam to do a radiation segmentectomy. I cone beam everybody. Pre on the MAA study on the mapping, right? And then I have a very low threshold to cone beam on my delivery. If something looks off, I don't like it. The perfusion has changed. If I'm using a balloon catheter or something pressure directed, I will recone beam, and I'll do it during the delivery, and it is standard in my practice. So I think it brings up a whole can of worms, but the question is always, how do you democratize it? If you don't have cone beam and you don't have SPECT,
I think there are issues. Obviously, I mean, there are going to be problems, and I think you're going to get humbled. We cone beam on our deliveries too, from the area we intend to treat, prove that everything's the same.
Cone beam CT parameters, injection rates, spin rates. What do you guys typically do?
So we do power injection proximally. It is 2 for 22. It's a 5-second spin with a 6-second injection or 6-second X-ray delay.
Okay.
So it's 11 seconds total with a rate of 2 times 11, 22, 2 for 22. I do that from the low bar. I do it from a proximal left, proximal right. And then obviously when I get further out, I use forearm strength for no reflex control.
Okay, so we do 5-second spin 8-second delay, so a total of 13 seconds. And I have a 3-2-1.5 rule. If I'm doing common hepatic, 3 for 39. If I'm doing a right lobar, 2 for 26. Okay. Left lobar, depending on the size, either 1 for 13 or 1.5 for 20. And then for segmental, usually 0.5 for 6 or 7.
And I think we're all aligned. Proximal cone beam CT is imperative to success.
I think so.
Yeah.
First.
Yeah. First step after you get it. Yeah.
As for people that go hunting first, you wind up getting burned, and then all of a sudden, it takes so much time to come back and retrace your steps. If you do that proximal cone beam CT first, you wind up seeing everything the way that you need to see it. And so if you say you catheterized the wrong vessel or you were burned, you have a reference point to go back to. You got to do it first.
And sometimes you see other lesions that,
agreed,
because there is delay, and this happens to all of us. The MR that was discussed in the tumor board is 2 months old. So by the time you get to see the patient on your table, that MR is 3 months old. I had a case 2 weeks ago that she had a very large tumor in the dome of the liver. We did a cone beam proximal, and then I realized there were not tiny, 1.5, 2 centimeter lesions in the corner of segment 2 and 3. One was obscured by the heart motion on the MRI, and the other one was right next to the gastric wall. So none of them were visible on the MR that was a month old. I had to bring her back to do the treatment for those as well. So those are the things that you're not going to see if you don't do the proximal.
100% agree. My protocol, I have Philips. I can't remember if I mentioned that earlier or not. So I actually have access to dual phase scans. So then I'm less worried about perfusional differences and changing my x-ray delay. So my standard, I try to get a base catheter out into the proper hepatic, and then I'll do 2 for 20. I have a 5-second x-ray delay, 5-second spin, and then that's my lobar. And then I take my lead off and I sit down at the station and I figure out where I'm going to go, and I spend 10 minutes doing it. And it always pays dividends for me. So
Agreed.
I do that invariably, pick my spots. The one nuance for me is I will do a DSA at every location to inform my injection rate for the cone beam. I do that very commonly if I'm not going to hand inject, to your point.
Power injection DSA?
I'll do a low volume power injection DSA to inform my cone beam so I'm not getting a bunch of reflux and then I can get an
I think that's reasonable. Yeah. And I inject, so I work my way proximal to distal, right? So you start celiac, then you go common or proper, then you go lobar, then you go segmental, then you go subsegmental. I think you have to work, or even if it's an anterior posterior division on the right, you work your way proximal to distal, and you do DSAs at each step. Sure. Especially if you're going to be doing a lot of them, or you're going to be treating a patient 2 or 3 weeks later, and you're not going to remember where you were. It informs you for how you made it to the spot that you need to treat from.
Yeah. Well, and it's not uncommon for me in my practice. I don't know how you both feel, but in a complex lesion, large lesion, multiple rad segs, I could do 10 cone beams in a single mapping, and that's not, my techs like to make fun of me, but I don't know how you both. What's your average number of cone beams?
5 to 6.
5 to 6, yeah. Right? Very common, right?
4 to 5, something like that.
And
Yeah.
I
have no qualms about it.
None.
To me, yeah. I do as many of them as I need. I don't, because it becomes easy to set up. As you said, we put the arm next to the patient. We are doing radial for the most part, but it doesn't matter whether it's radial or groin. As long as the arm is next to the patient, the setup is very easy. It's basically essentially similar to a DSA. It's just a little bit longer, but it's almost the same. Yeah.
Well, and your cone beam is, again, paramount to success, right? So I have a 90-90 arm positioner. I can leave the arms up and it's relatively comfortable for patients. I do some of my mappings out of general as well. I don't know if you're both using general anesthesia for mappings ever.
We do. So Ochsner we have some hospital policies. If you have sleep apnea, anesthesia has to be involved in care. And so so a lot of people have sleep apnea, especially when Popeye's poisoning is prevalent in your region. So a lot of people have sleep apnea. So if anesthesia has to be involved, I need breath holds. And so if we have to use general anesthesia, patients wind up needing to be intubated so that we can do breath holds.
Well, it's helpful, right? I mean, if they're moderately sedated and they can't follow instructions, you're going to get crappy code beams.
Yeah.
Oh, see, I yell at patients. I'll yell, I sternal rub, I pinch toenails. We wake up.
Okay.
And so
this is a very important point, that if you are using anesthesia, ask for GA. Don't do propofol, because you're going to become frustrated. The anesthesiologist is going to become frustrated. Most importantly, you're going to get garbage information that is not going to be helpful for your treatment planning.
Yeah, my patients are either awake, minimally if at all,
Arousable. Yeah.
arousable,
Yeah.
or GI,
Some
full paralysis. Sorry, I totally agree with that. Okay, so access sites, you said radial.
I'm a femoral. I'm 100% femoral. I can do radial. Our rooms are not well set up for it. Every time I've ever done radial, the arm has been out, in a cross-like position.
That's very annoying. Yeah.
If you're trying to do a cone beam like that, it's damn near impossible, right? And so I'm sure you've navigated those problems easily, and I'd love to hear how you do it. But we do femoral. We've had no issues with femoral. Our techs are well equipped to set that up rather than have to have them be very good at radial and femoral. Femoral makes the most sense for us.
Yeah. Well, and the other thing I would say, and I learned this when we were together at Emory, and we did a lot more radial at Emory. Big patients, lesions far to the right side, keeping the left arm down, which is what we often do for radial. Sometimes you just can't get the cone beam all the way over there, and that's
with Siemens you can. Okay. There is actually so I'm a huge radial fan. Yeah. We do it the Sinai way because I learned from Zach Burke, our partner at Emory, who was trained at Sinai. Arm next to the patient. I particularly like it because my order mapped feet, I bring them back the next day. I can use the radial again. I don't have to worry about a closure device that I've put in. I don't have to go to the other side. I think it has a lot of advantages. And in terms of stability, particularly if you want to do segmental or subsegmental treatment, I like to use the MG1 catheter, I take that to right hepatic, left hepatic.
It's a Terumo glide cath.
It's a Terumo glide cath version of a Sarah or Jackie radial.
So no issues reaccessing the left radial artery next day?
I've never had an issue. I've had a radial artery thrombosis months after the initial Y90, and it was partially thrombosed. We could still access it, but the patient was completely asymptomatic because we always check for Barbo and all of that. But no issues so far.
I think there's misconception around glide caths. There's 3 different types, right? There's a 4 French double braid. There's this 5 French single braid that is a complete noodle, and there's a 5 French double braid, which the MG1 comes in a 5 French double braid. So that's the one that
I knew about all of those details. I was just give me an MG1. I've heard good things.
Some people just gotta make it even hard.
Well, that single braid, single braid just doesn't work. So anyway, side note, I digress. I'm sorry.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Yannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandow.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.